Welcome. Come with me. The doctors will see you now.
Welcome back to Fast Talks with Family Docs. I'm Dr. Phil Palmer.
And I'm Dr. Veer Wadala. We've been sitting with Dr. Robert Salinas, talking all things geriatrics and having a fascinating conversation. We're back today with him for part 2 of our episode, where we might go into further info about geriatrics, and we'll talk about team-based care. Dr. Salinas, Thank you again for being here, sir.
Oh, you're welcome.
I had a follow-up question to our last episode. There's a lot of providers out there who are already done with residency, kind of into practice, 3 to 4, 5 years old, like me, right? We have our population, a lot of them are in that geriatric age range, definitely above 65. We have a high Medicare panel. And we're doing the best we can. If we wanted further info or to improve our own training, do you have any recommendations of CME that talk about geriatrics, or maybe even a little bit of assistance in us helping our patients navigate through that end-of-life care that doesn't involve like a full-fledged fellowship again, maybe?
Mm-hmm. Yeah, thank you for that question, and maybe I should have answered that in the previous segment. The American Geriatric Society has a lot of resources. They even have a wonderful journal that lists a lot of courses, CME courses throughout the U.S. I attended the UCLA course out in Los Angeles, California, which is a wonderful course many years ago, and I've done it a few times. But there are a lot of resources out there in case you may want to learn a little bit more about caring for the older person as well.
Yeah.
The American Geriatric Psychiatry Association, I believe, has a wonderful course as well.
Wow. That's awesome.
So there are many opportunities to keep learning about caring for our members of our geriatric community. So
that's great. Thank you, sir.
You're
I think that's good for our listeners to know.
Yeah, definitely. So you've been a proponent, an advocate of team-based care. What does that look like? Should that look like in your experience, and why do you feel like that's crucial for healthcare in this day and age?
Well, that's a very good question, and so let me maybe start with how it came about. I got involved with patient safety and quality improvement, and this concept of team-based care is I believe medicine is a team sport, and we have to look at it that way. The days of a one-risk approach are gone. But when I was a resident, going back to residency again, my co-chief resident, Tina Cooper, who I think practices in Ada, we were interested in the fact that we were discharging patients from our hospital, and maybe 300-400 yards away, we had our clinic. And between the hospital and clinic, information would get lost. Right. So this was back in 1998, and Tina and I came up with an idea of creating a document called the Day of Discharge Summary, which is a triplicate form, where we would give to the patient, this is what happened during your hospitalization, this is your follow-up appointment. We would give one to the medical records people, give one to the patient, and the third one we would put in the mailbox of the provider that was going to see the patient on follow-up. So we thought, okay, something's happening here. So my lens is, kind of adapted, where I started to see the world a little differently now. And then not too long afterwards, I think it was Eric Coleman, who's at the University of Colorado, came up with the term transitions in care.
Oh, yeah.
So we were a little bit ahead, but he gets all the credit for picking up that during a transitions in care, you have a lot of opportunities for failure. Right. So we started to really take a look at that back then, and then over the years, I learned a little bit more about patient safety, and I was able to take a course with Peter Pronovost at Johns Hopkins that really kind of laid it out in terms of what actually happens in the U.S. when people get hospitalized. It's over 100,000 people that die in our hospitals, and those younger and those older. And of course, as a geriatrician, I gravitated towards taking a closer look at the older person. So realized that perhaps folks were at higher risk for a number of reasons that we talked about in the previous segment. But I started to get interested in that, and then realized that at one time, medicine was a very one-risk approach, that the buck stopped with us as physicians, when in reality, it is a team sport. Yeah. And I will share with you that a lot of people felt if you can just get along as a team, you'll do fine. But there is a science behind it, and that science is there. Our colleague Eduardo Salas, who's at Rice University now. He's doing some wonderful work on the concepts of team, and we moved it into the healthcare system. In fact, Eduardo is actually working with NASA to help prepare and recruit and prepare the team that's going to go to Mars. So if 5 or 7 folks are going to be traveling to Mars, so you got to get along, right? You just can't go there halfway and said, fine, we don't like you, so we're going back. So Eduardo has a lot of science to it, and our colleague at Harvard, Amy Edmondson, has talked about and written about the concept of teaming. So team-based care, there's a science to how do we work together to provide the best care that we can for the patient. And there's a science to it besides getting along, cooperation, communication, clarity in terms of what are the goals for everyone to do well. Whereas Amy Edmondson has introduced the concept of teaming. And just to give you and listeners a quick example, in a hospital setting, in the emergency room, you may have the emergency room team that practices and rehearses together respond to a patient care need. However, teaming is when you have people that don't practice together and rehearse. Right. How is it that they can still come together and deliver the best care that they can? So that's how I got interested in this. And as I said, I've evolved over time where I've really started to take a look at not so much what they call the sharp end of things in terms of the provider themselves, but the system and the process. Yeah. And that's a system that we create. Yeah. So
what does that look like in a clinical setting, I guess, like in a primary care clinic? We have the group of physicians, the APPs that are there, like the behavioral coordinator, and then you have the resource navigator and stuff. And then I've been hearing about these like huddle groups where it's like a couple of physicians together with a couple of APPs, and then they're a group, and then, like in a multi-provider system. Can you give us a little bit more example of what you're working on or what your thoughts on that are?
Very important. As I said before, the science behind this suggests that if you can create effective teams, in fact, I'm going to say this, there's a wonderful book called The Patient Comes Second.
Oh, yeah. I've heard about that.
Yes. Yeah. And it's very provocative. When I read the book, it's written by our colleagues down in Dallas. I think they were at Baylor. And I thought, wait a minute, the patients come second. And since then, really what they're talking about is if you take care of your team, the healthcare delivery for your patient will do well. We often hear from our hospital systems that patients come first, which is important. Right. But it goes back to your point that if you can work as a team that's effective, a high-performing team is what we call it, the care delivery will get better, will improve. Right. In the clinic setting and in the hospital settings as well. But that's been proven at some of the major institutions, the Mayo Clinic, the Cleveland Clinic, the UCLA. If we strive to really do that, we have to, as you said, start with the person that sits across from you, and how do we huddle? How do we work together? And there's a little bit of a secret sauce, if I can add to that. Yeah. So along the way, people say, "Well, is it just about getting along?" And so Amy came up with this idea along with another person, Tim Clark, and the concept of what's called psychological safety. Oh. And psychological safety is something that when I do a little bit of leadership training or when I meet with students and residents, I use an example. And that example is, and I'm sure I usually get 100% on this when everyone raises their hand. I said, how many of you have been in a situation where you wanted to ask a question but just couldn't?
Sure.
And why was that? When you said, okay, I was a student, a resident, and I wanted to ask a question, but I just couldn't ask it for...
I didn't feel silly.
I would look silly. Yeah.
I would look silly. I would.
It wouldn't be received well.
It wouldn't be received.
I'll become a target.
Yeah, well, well, look, I just got 100% here. So far I'm okay. But Amy has taken this further, and she really talks about how that is important. That if you can promote that concept with your team, you may have your nurse who might speak up and now say, hey, Dr. Videla, did you really want to send this medication to that patient because the EMR says he's allergic to it? And if she feels safe enough to come up to you and what they call the challenger component, she may help prevent an error.
Yeah.
And so the concept of psychological safety is now making its way into medical education, our residency programs as well. And that's because we've all been there, where we've been on rounds where we wanted to say, hey, Dr. Salinas, did you really want to use that antibiotic? But I just couldn't say it because of the comments that you made.
Yeah.
So we really encourage our learners to feel safe in asking us those questions without any fear of retribution or thinking differently.
Yeah, thank you for that. So, Dr. Salinas, the healthcare in general has a workforce shortage, and physicians and nurses and really other mid-levels and ancillary providers. Where do you see right now in primary care and especially in geriatrics of being some of the biggest needs for the future, for now and into the future?
Yeah, well, actually, we were discussing this prior to going on the air and recording this with one of your colleagues here, and we were discussing the need for nursing care and the need for physicians as well. In my role as the Assistant Dean for Access and Community Engagement, I spend a lot of time trying to recruit students into the field of medicine or the healthcare workforce. I've taken a look at some of the data, and I'm concerned that the number of students who reside in Oklahoma, who say that Oklahoma is their residence, the number of applicants to medical school has gone down, and the number of matriculants has gone down a little. But we're starting to see a drop, and that is from 21 to 22. We're starting to see that drop, and we were excited. People called it the Fauci effect when we saw the increased numbers, but now we're seeing a decline. But I am worried, and there are many reasons for that in terms of what's happening. We're seeing more burnout, for example, and let me just say this, that I think the height of the pandemic, we saw about 63% of physicians were having symptoms of fatigue and burnout and more of the stress. And more recently that I've read from the AMA actually is that we're at 49%. Well, we've gone down, but that's almost still
That's still pretty rough.
Still pretty high.
It's almost 1 in 2.
Almost 1 in 2. So we have to try to figure out what's going on, and we're seeing burnout more in younger physicians rather than the older physicians as well. So we have to start thinking about how do we energize students that may have an interest in the healthcare workforce, and then how do we better prepare them? Yeah. So I am fortunate enough to work with high school students and college students who aspire to become a doctor someday. And a good part of what we do is we coach them and their families in terms of how to do well academically, how to prepare for this exam called the MCAT that they all have to take. But it is challenging, and we're really worried that perhaps this idea of closing the gap may not happen, especially with geriatrics. The last time I checked, again, there's about 7,000 board certified. What that means is that family physicians and internists are going to really have to help provide the heavy lift for our aging population.
Yeah, definitely. I mean, you speak in our language here, sir. I think there's just, it's just like, speaking of these experiences that you have, or, the residents or neurophysicians experience a lot of this burnout, you don't tend to remember the positive things, but the negative things that happen these days, and there's just a lack of appreciation. Yeah. And even today, and I'm not trying to vent here, but for our listeners, I did a lot of work for a patient, and the response I get was thanks, I guess, when I called him after, and it's just, that I get it, I feel it, and I think that's what has to change is the attitude towards physician. They can't be villainized anymore, and that's a huge problem we're having, I think.
I agree. I think part of it is, we do a lot unconditionally, and so some of the strategies we were talking about earlier is remaining as centered as you can on meaning and purpose, and that will help drive the why. But be careful with the why existentially, because sometimes you can overdo it and say, I can't find the reason why. So go to what? Yeah. But I think reflecting on why is it that we went into this profession, to help the infirm, to help heal, and as we were talking about, to help some of our patients on their journey of life, and even if it comes to an end, we still are part of that journey. Yeah. But earlier we were talking about the EMR and how there was a big expectation that the EMR was going to solve a lot of our burnout.
Yeah.
And I will say that I don't think we've really seen a lot of that, but I found in my practice, and Phil and I were talking about this earlier, when we write a note, when we craft a note, I see it as a form of journaling, which journaling in itself could help prevent the burnout. Yeah. So every unique story that our patient tells us, there's a sacredness that occurs when you're in a clinic with the person and they're telling you their deepest worries, and you get to listen and you get to write that out, and you get to journal it in a story that makes sense to you and the next reader.
Yeah.
But I think there's something magical, and I'm going to maybe sidebar if I can, because you were asking me about telemedicine and where that is happening. But I really believe that, one way to guard against the burnout when we're in clinic is to really get to know our patients a little bit more and understand the narrative component to it. But I'm a big fan of trying to understand the neurochemistry of the encounter. Yeah. Which led me to read a wonderful book by Paul Zak called The Trust Factor. Paul's at the Claremont Institute in California. But there's something magical that happens, and I'm going to take you back to biochemistry. Don't worry, there's no quiz here. Wait, we have a resident in the room. But so this concept of caring for the person that sits across from you have something magical, and something magical can happen. And what we're finding, and folks at Harvard and Claremont are doing the wonderful, wonderful work now with what we call saliva testing. But we can measure the cortisol levels, the neuroadrenaline levels, the oxytocin levels. Yeah. Mm-hmm. And guess what happens when we can interact with the person? And I tell my students and residents that are with me, sometimes they'll see me in clinic and they say, how come you put your hands on your patient's shoulder all the time? Even though you're talking to them, you hold their hand to check their pulse, and you check their pulse in both hands. Well, I'm really touching them. I'm really healing them, in my opinion. And when I put my hand on their shoulder to listen to their heart and their lungs, and so the experts tell us what's happening is that we are releasing their oxytocin, the love chemical. Yes. Their dopamine levels can change as well. But something magical happens, and that's because of the mirroring effect. They change ours. Yeah. Right. So trying these things, I think, in clinic are important because we're so used to trying to document as much as we can. But I think that's another way to approach the burnout that we're experiencing by understanding what our role is in the person who sits across from us. Yeah. So
it's more than just knowing the right drug and the right dose of that drug to bring healing to somebody.
To bring healing to someone, that's I like that. I might have to use that if I ever write a book. I'm going to quote that.
There you go.
To quote Dr. Phil Palmer.
Quote Dr. Palmer.
What a positive way, sir, to end this conversation.
That's just what I was going to say. We're out of time, but Dr. Salinas, thank you so much for joining us. It's just been a very valuable conversation. Dr. Vidala, great seeing you
Always
again.
A pleasure, sir.
Yes, and viewers and listeners, thanks for your time. We'll see you in the future on another episode of Fast Talks with Family Docs.
Thank you for joining us today. The doctors would like to see you back for another check-in. Please choose to follow our podcast and you will automatically be notified when it's time for your next appointment.